see that Eddie is on as well.
I missed him.
So we have a quorum of our voting members. I know Diane cannot be here today. And have you seen TJ Lidovic?
He just joined, it looks like.
Okay, wonderful.
It's here.
Good. Thank you very much, TJ. So we have 6 of the 7 voting TAC members. So we'll open the meeting. Welcome to you all. This is the umpteenth meeting of the Behavioral Health Technical Advisory Committee. And we are glad to see you all. If we could have the voting members of the TAC just say hello so that the court reporter will know that you're here. Let's see, Steve.
Steve Shannon, CARP.
Okay, and Valerie.
Valerie Mudd, NAMI Lexington Participation Station, Consumer Voice.
Thank you. And Mike Berry.
Mike Berry, People Advocating Recovery.
Thank you. And Eddie Reynolds.
Eddie Reynolds with the Brain Injury Alliance of Kentucky.
Thank you, Eddie. And TJ Lidovic.
Hello, TJ Lidovic, lobbyist for NAMI, Kentucky.
All right, thank you very much. And I'm Sheila Schuster, representing the Kentucky Mental Health Coalition. So we have a busy agenda today, and we'll get right to it. I actually sent out 2 different emails. In the first one, we had the draft minutes of our meeting of March the 10th. And from this, I made the report to the MAC in March. So among the voting members, I would entertain a motion to approve the minutes of the March meeting.
Steve Shannon, so moved to approve.
All
I'll
right,
second it then, Val.
and Val seconds. Any additions, corrections, omissions? If not, all of those in favor of approving the minutes signify by saying aye.
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 And abstentions and disapproval. Thank you. Thank you very much. The first item on our agenda is, well, this agenda, I had the summary of data from Medicaid on targeted case management issues. Anyway, we actually don't have a report yet. We have gotten more information from Medicaid and are excited to be looking at that. And we will be talking with the commissioner about those numbers and the sense that we're making of them. And hopefully in July, we will be ready to give a full report to the BH-TAC. So let me move on then to the presentation by Aetna on reducing Sky members' polypharmacy use. And Kat Jones from Aetna, and I don't know who else you have. And do you want to share your screen, Kat?
Actually, Kelly Pullen is going to be driving.
Give me just a second, Kelly, and I'll make you a co-host.
Thank you.
You should be able to share now, Kelly.
Thank you. All right.
Yeah.
Good afternoon. I am Kelly Pullen. I'm the Executive Director for the Kentucky Sky program here at Aetna. With me today are my wonderful colleague, Susan Vickers, who is our Quality Improvement Director for Sky, and Megan Johnson, who is our Quality Management Nurse Consultant. We've got about 20 minutes to spend with you all day to talk about our collaborative population health approach to lower psychotropic polypharmacy among system involved youth. So quickly, I'm here. I've got the easy part, which is to introduce Sky. For those of you that don't know what Sky is, that is the Supporting Kentucky Youth Program. Aetna was awarded this sole contract to serve children who have been impacted by child welfare and juvenile justice. So In just a quick summary, that means we cover their Medicaid benefits, but in addition to that, we really have a robust, high-touch approach to care management that really helps families navigate systems and makes it easier for them to get the resources that they need.
Kelly, can I stop you for just a minute? Guys, if you're not presenting, can you please mute so that the court reporter can make sure to hear everything, please? Thank you. Sorry about that, Kelly.
No problem at all. So we like to walk people through, our purpose for SKY. We have 4 primary goals within the program, and the first is to incorporate youth voice and choice. The second is to improve their long-term health outcomes. The third is to achieve safety and permanency for our children, and the fourth is to reduce psychotropic polypharmacy among our system-involved youth. In terms of who's eligible for SKY, you can see all the different groups on the screen. Essentially, we're serving kids that are currently committed to foster care, the Department for Juvenile Justice, but we're also serving members who may be receiving adoption assistance, and we serve former foster youth up to the age of 26. For our care coordination model, we have a really high-touch approach to care management, very reminiscent of what you may see from a provider perspective being done here at the health plan. Our team members have experience and training coordinating and providing those physical and behavioral health services to our members who are eligible. All have a background in working with youth that are impacted by child welfare and juvenile justice, and they're here to really help provide a lot of different services. I won't go through all of them on a screen, but you can see they're helping to locate providers and obtaining appointments. We've got some priority providers that are helping us expedite the scheduling of appointments for different assessments for our members. We're assisting with those coordination of covered transportation services for our members, and really helping to link our kiddos and their families to those community-based resources that they need. Our care management model is tailored to meet the needs of each of these kids and does include some different complex levels or tiers, as we like to call them. And how a member gets stratified into those tiers to dictate the level of service that is being provided is really through our assessment scoring and member risk stratification. So our team is taking that child and adolescent needs and strengths assessment, combining that information with our foster care health risk assessment, our SDOH screener, and a supplemental assessment that we use here at Aetna. They're also taking into account all of the condition-specific screeners that we provide to our members and determining what tier they should stratify into for care management. Pop Health is our lowest tier. Intensive care coordination is our middle tier. Complex care coordination is for our most acute members in the program. And this slide just walks you through a little bit more detail about what that means. Complex care coordination is for our enrollees that have the highest needs, our most acute kids that maybe have previous behavioral health admissions, or those that have special health care needs. And this does include all of the kids that are designated as medically complex by the cabinet. Our staffing ratio in this tier is very low, definitely one that we're not necessarily used to seeing. From an MCO, it is 12 kiddos to 1 staff member. And you can see the services that they provide. They're providing 2 face-to-face visits monthly, weekly contact, a minimum of 2 hours per week of care coordination, a monthly team meeting, and care plan updates as well. For those kiddos that are in this tier due to behavioral health reasons, their care managers are certified in high fidelity wraparound and are actually providing high fidelity wraparound care management to our members. For those kiddos that stratify into that intensive care coordination tier, those are enrollees that have moderate acuity, but they're not really at risk of crisis at the moment. Staffing ratio there is still pretty low. It is 1 staff member to 32 kids. Services provided look very similar to what you see above, with the exception of 1 less face-to-face visit, and they don't have that requirement to have that minimum of 2 hours per week of care coordination. Our team members in this tier are not certified in high fidelity wraparounds, but they are trained in it and are providing high fidelity wraparound informed care management. And then our lowest tier that we have, we call Pop Health, which is really our prevention and wellness. That's for our enrollees that have limited healthcare needs. That ratio is 1 to 400, probably more reminiscent of what we see from managed care management. And with that, they still have access to our care managers and our services. They're actually being outreached by our team members on a quarterly basis. But, if any issues arise, our team members are assessing them and able to move them throughout this continuum of care management that we have here for our members. So it's a very brief, quick, high-level overview of SCI and care management. I'm going to turn it over next to Susan, who's going to walk through psychotropic polypharmacy.
Good afternoon. I'm Susan Vickers. Again, I'm the Director of Quality for the SCI program. And we want to just really, before we share the nuts and bolts of our program, Kelly set a beautiful stage for SCI in general. And now we would love just to kind of lay some groundwork of what this population really does look like and show you how kind of the challenge of psychotropic polypharmacy has really shown its face in this population. So next slide, please. So one thing I'll start with, we, as part of our contract, really were challenged to collaborate with DCBS, DMS, DJJ, and all of our system of care partners to figure out a way to collaborate and help solve this issue among our system involved youth. This is, as you all know, every day, just a highly sensitive population. They have, as you can see, our ACE assessment scores and the prevalence of those higher, 5, 6, 7, 8, 9 scores on the ACEs is very high among our population. We have a high prevalence of SDOH needs through the assessments that we're doing upon enrollment and on an annual basis with our members. And then each of these members, especially those, currently in that out-of-home care, really do have experience and have been through this cycle of trauma, as you can see there. So we also have such a high prevalence of behavioral health diagnosis in our population. We have about 28,000 members as of this month. And last year in 2021, we had about 17,000 members who had a behavioral health diagnosis on a claim last year. So we're looking at about 62% of our population who are affected, somehow with a BH diagnosis. Next slide, please. We also know that psychotropic polypharmacy, with all the good work that's been done in the past 5 or 10 years, is highly prevalent among this population. Our Medicaid insured youth are 3 times more likely to be prescribed an antipsychotic compared to those on the commercial side. And then our foster youth specifically are twice as likely to be prescribed as those other Medicaid insured youth. We see higher levels of psychotropic meds, typically experienced in out-of-home settings. So this is just a high need. And we see it as a pain point in our system that we hope we can work together to really, eradicate is my dream. So next slide, Kelly. Before we go really any further, we want to define what we are considering polypharmacy and psychotropic polypharmacy using peer-reviewed literature. Dr. Lohr from DCBS has really been our guiding force in this and such a wonderful partner. One of he and his peers published an article last summer that really did help us stratify our members into kind of 2 levels: the psychotropic polypharmacy, the meeting of that kind of criteria with 2 or more, at least 2 or more classes, and then a higher level psychotropic polypharmacy with at least 4 classes of psychotropic meds, at least in the last 30 days during a calendar year. So, when we started these efforts, we really struggled on how are we going to define this? How are we going to stratify this population? And these definitions have definitely been helpful in our program and in our approach. Next slide. So now that we've kind of defined those definitions, we can explain that For psychotropic polypharmacy in our SCI population, as of last quarter, about 10% of our members met that criteria of at least two classes of antipsychotics. And then 3% of our population met that criteria for high-level psychotropic polypharmacy, which is at least 4 classes. Next slide. So another, as Kelly said when we very first started, that youth and family voice, choice, and preference is paramount. It's one of our guiding forces. And I think one of the very, very helpful resources that we've used through SAMHSA were some focus groups and listening sessions that were done at the national level among many, many different families and youth, and really shared that there is a high concern among families, among youth, related to giving these medicines. They need their information in lay terms that they can understand when they're discussing this with their providers. They need prescribers really to provide as much information as possible about alternatives to the treatment option of using an antipsychotic medicine. What are the other alternatives? What are the side effects? What are things that can be done in conjunction with this treatment option? And then the last really main point that was shared was the need for development of young adult and transition age youth targeted education material. So as you'll see when we get to Megan's portion and showing you all some of our interventions, this has been a guiding force for the development of our program. Next slide. And finally, you have to use some good frameworks in order to prop something up like this, especially in the past year, right, Kelly, of developing and implementing our SCI program. And SAMHSA really does provide all of us this framework. There is a framework for best practice in antipsychotic prescribing, and that really does use a system-based strategy for system level change. And that really does involve engagement, as we mentioned. It involves multimodal interventions and approaches, engagement of prescribers. We'll show you a little bit about some of the interventions that we've started with prescribers. And then just considering the unique needs of this population, which we've covered just now. We've worked really hard to coordinate with all of the different systems and sources of care among us, and also looking for that just a financing mechanism to make sure this all happens. I think one thing that we've really worked hard to reinforce is that very last column, the making sure that all of our interventions are trauma informed, that we're pushing as much evidence-based practice in our system of care and supporting that through Aetna's initiatives, and also being as open and honest as we can about this and showing everybody that we know that this is an issue that we want to fix together. Next slide. So Megan's now going to explain our approach and the programming that we have implemented in the past year.
Hi, my name is Megan Johnson. I am the quality nurse consultant for the SCI program, and I'm going to be talking about how we have approached addressing psychotropic polypharmacy in the SCI population. So our program has some overarching goals that we would like to achieve, and I'll just review those real quick with you. The first would be, of course, to reduce the number of members who meet criteria for high-level psychotropic pharmacy. So that would be those kids who are on the 4 or more classes of medication. So we definitely want to decrease the number of those. We also want to reduce the overprescribing of psychotropic medications when a non-medical clinical intervention is appropriate. So if we can manage symptoms through therapy approaches, we definitely want to push for that. We want to increase the appropriate metabolic monitoring for those who are prescribed antipsychotics. So we have a lot of kids who are on antipsychotics and haven't completed metabolic monitoring. So we really look at that, and we track, you'll see in a few slides, we track that over time. And we also just want to increase education among prescribers, DCBS staff, DJJ staff, caregivers, children and family, and foster parents, and then the transition age youth. We want to make sure that they're pushing informed consent and making sure that the prescribing practices are appropriate. Next slide, Kelly. Susan mentioned a minute ago about how we stratify these populations. So what we do is we kind of put our kids into 3 buckets. So we have that high level psychotropic polypharmacy bucket, and those are the kids that are on 4 or more classes. Then we have our psychotropic polypharmacy level. Those are kids that are on 2 or 3 classes. And then we have our rising risk children who may be on 1 medication. They're really young. They haven't had any BH visits. Their placement has changed several times in the last couple of months, and they may have had an admit to a recent to a hospitalization to a psychotropic hospitalization. I'm sorry. Next slide. In our polypharmacy program, we do a lot of different interventions. We have a multimodal model. We work with DCBS, DJJ, DMS, and provider networks to ensure that all partners at the table are aware of medications that the members are on and feel that these are appropriate choices. We take a trauma-informed approach and we apply those principles anytime we're working with members. We share population and individual level data and analytics, and drug utilization reviews are completed on a lot of these kids. We have our pharmacy team come in and they look at the medications the children are on. We also have recently invested to increase access to evidence-based psychosocial interventions. So we recently provided some money to increase the number of providers in Kentucky who have EMDR training. We also have created several caregiver and youth-directed education in lay terms, and we call this our Medication 101 education. This is what Susan mentioned that was needed in this population. They want to understand it in lay terms. And we also work on prescriber education. So going back to that informed consent and de-prescribing, which Dr. Lohr explains is just a conversation about the medications and making sure those are appropriate. And then our team, our pharmacy team, and Dr. Lohr does a lot of provider outreach and like I mentioned before, the clinical pharmacy reviews. Next slide, Kelly. So how do we do this? How do we touch these kids? We have a high touch care management approach, and once these kiddos are identified on our internal report, they are stratified, and those that are at highest risk are taken to our case rounds internally. They also may be referred for a consult with Dr. Lohr. Those are 1-hour conversations with the interdisciplinary care team that occur on one child at a time. So we have completed several of those in the last little bit. You will have some numbers on the next slide. And then after we do these consults and these reviews, we go back and we look at outcomes after 90 and 180 days. So we want to know, have our interventions made a difference, or do we need to revisit this kiddo and see if we can change our approach? And then we look at our outcomes and monitoring. You'll see on the next slide, Kelly, sorry. Here's some of our outcomes for 2021. I mentioned before on the right, you'll see the graph for metabolic monitoring. In our SCI polypharmacy population, we actually have a very good rate of metabolic monitoring for those kiddos who have had both blood glucose and cholesterol testing if they're on an antipsychotic. We started at 5% in first quarter last year, and preliminary results show that about 45% of our kids who meet the criteria did complete both blood glucose and cholesterol testing. We also completed 173 of those polypharmacy rounds that I mentioned and those DCBS consults. That was from 1/1/21 through the first quarter of 2022. And on our outcomes tracking system, we were able to identify that at 90 days post-rounds consults, 28% of our members have generally successful outcomes. And then when we go back and look at 6 months at 180 days, about 44% of our members have generally successful outcomes. So we're seeing that the more we work with these members and the more time we spend with interventions, that we have better outcomes. And over in 2021, we were able to reduce the pharmacy costs among these members by 23%. Next slide, Kelly. So future state, we have lots of plans for our polypharmacy program. We have a lot of future opportunities that are in the works. We're hoping to build a community roundtable that would include BH providers, DCBS, DJJ, DMS, prescribers, youth and family, and pharmacists. We're hoping we can get everyone to the table and get some interventions in the works. We really want to have some feedback to make sure that we're doing everything we can for this population. We also want to increase prescriber education on de-prescribing and informed consent. This is something that we're very passionate about. Like I said, de-prescribing is not asking providers to quit prescribing. It's just a conversation about whether or not medications are appropriate. We also want to partner with community pharmacies to see if we can get these kiddos at the point of sale. So if we can engage them when they're picking up their medications and hopefully get them in our case management program, we really want to make sure that they have all the information that they need. And then we're also in the process of creating some transition age youth directed programming to address those needs among that population. And then, like I mentioned before, we are working to increase the access in Kentucky to evidence-based practices with our EMDR programs. And I think that's everything. Kelly, I can turn it back over to you if there's anything you want to add.
I was just going to add, thank you so much for the opportunity to present to you all today. If you have any questions, feel free to let us know. Our team's here and happy to answer any that you may have.
Thanks so much, Kelly, and all of you on the Aetna team. Will you make these slides available so that everyone who's on can get those?
If you can email it to me, I can send it out to the entire group and also post it on our website. And I'll drop my email in the chat.
Yeah, if you'll email it to Erin. Thank you, Erin. I have a couple of questions that are more specific because I remember when this information was first presented, this goes back years ago. There were a couple of things that really struck me. One was how many very, very young children were on psychotropic meds for which there really is no FDA approval. And I wonder if you have some breakdown in your data on that issue. Let me tell you what my other issues are, and then you can tell me if you've got that data. That was one. The other was an inordinate number of kids, and again, this goes back 6 years ago or so, who didn't even have a behavioral health diagnosis, but were on at least one and sometimes multiple antipsychotic medications. So I wonder about that. And then the third thing that I remember clearly was what looked like a correlation between number of meds and the number of different placements that a child had. So it almost looked like every time a child was put into a new placement and the first sign of trouble or whatever, another med was added. So I wonder if you have any data on those points, please.
We have tons of data on all of those points.
I'm sure you do. I guess what I'm looking for is some hope that things have improved in all three of those categories.
You know, I was just saying to Kelly and Megan, like we aggregated our report so much in the beginning, looking at age, looking at placements, and now we've used that more as triggers for our member level intervention. So when we see a 6-year-old, that member literally automatically rapidly goes, you know, into a higher tier and goes straight to our rounds. And so we will definitely get that aggregate information to you as far as over the past year, how many 6-year-olds. I know that when we've aggregated the utilization kind of population, we've seen that age, really the 11, 12-year-olds were our highest kind of in the bell curve. But as far as the prevalence among age 6 and under, we can definitely get that information to you. And then we also, again, use the placement stability report that DCBS provides us so that we can see how many, let's say, children who have had more than 3 moves in the last 90 days. If a child is on that and on our utilization report, that also triggers a more rapid response and more focused intervention and a higher kind of risk stratification. So we can definitely kind of break down our latest population report into those categories and definitely get them to you. And I think we need to look at the diagnosis. We have that on the report, and I've never actually pulled the report by diagnosis with the none, you know.
Yeah, I was going to say, or whether they even have.
Right.
It's just amazing to me that we had young kids, again, without FDA approval, on a psychiatric medication with no behavioral health diagnosis. I mean, that was just, and I guess, and I don't know if David Lohr has access to that early information. I mean, I would love to see some comparison of where we are compared with where we were before you all were even before Sky was even conceived. But, you know, I'd like to think that we are doing better by these kids, because that first report was just terrifying. Marcy Timmerman just put in the chat, was absolutely terrifying. And those of us who have been in child clinical work for many years, just anyway, I'd love to think that we're making some progress. I love what you're doing in terms of interventions, and it seems very comprehensive, so that we have not only the data, but you also have mapped out some multimodal and multi-systemic interventions, which is really what these kids need. So I'll quit talking and see if we have any other questions from anyone, but I'd appreciate any follow-up that you can give us, Susan. Thank you.
I also like to know what class of provider is prescribing it. You know, pediatricians, primary care, child adolescent psychiatrists,
Nurse practitioners.
APRNs, nurse practitioners. Are there other folks who are prescribing these? You know, at one point I saw a list, and believe it or not, ear, nose, and throat docs were on the list, probably for sleep. But just so, you know, we really understand who's making these, you know, the decisions of being, you know, these pretty serious things, and who's doing that work. I don't know if you have that data as well.
We have a lot of data, like I said. And again, we actually, you know, the first 2 quarters of last year, when we were really just developing baselines, we did try to take a look at that class of prescriber that was attached to each of the kids on the utilization reports. I think we have some work to do on how to break that down. And I think too, and Kelly can help me explain this, I think what we saw at first, we were quick to judge, almost like, well, there's some prescribers out there that we need to look at. Well, actually, you know, when you break it down, if you take our however many thousand kids on this report and break it down by prescriber, many of them just have a high level or high volume of patients. And so it's really hard to kind of pinpoint, oh, there's an overprescriber out there. We've done some work, especially with our medical director, if there is, and our care management team has been incredible at this. If while they're reviewing these members on a monthly basis, if they feel those, you know, kind of red flags going up or notice some prescribing practices member level, then we're actually going in and looking at that. Is this a potential quality of care concern, and addressing it kind of member by member? Because when we looked at our big aggregate reports, it was really hard to drill that data down that was fair for prescribers and didn't, you know, kind of unjustly target someone just because they had a big practice.
And I would like to add too that some of those providers were working in outpatient and inpatient facilities, so they had a higher volume of prescriptions, and so it was unfair, like Susan said, to say that they were overprescribing when they just had a higher volume of patients.
Yeah.
So I was going to sum up. We have the data in terms of who those prescribers are. We just are very careful not to draw conclusions from it. So we can absolutely share the data. Our team is just being careful not to draw those conclusions, just given the nature and the structure of the system.
Well, the truth is that as long as we have the dearth of particularly child psychiatrists in the state, and even pediatric mental health NPs and so forth, we're going to have to look to other prescribers. I mean, there's no way around it. So I think that's a good point. Do we have any other questions from anyone of the Aetna team?
Question. I know personally, as a consumer, someone who has mental illness, I often have polypharmacy issues, and I know this is specific to youth. But I was just curious, when the polypharmacy is happening, are they using like super old medicines? Are they using a combination of all these different classes? Is it mostly atypicals? What kind of things are they using?
So we actually don't see a lot of atypicals used in this population, but we do see it sometimes. And I will say that our team, our pharmacy team and Dr. Laura have been fantastic. If they see something that doesn't look right to them, the first thing that Dr. Laura asks is that we do a psychological evaluation to make sure that the meds match the diagnosis. So that was something you mentioned, Sheila, and I would love to run a report and see if there are any who do not have a BH diagnosis. But if they've not had an eval in the last year or 2 years, Dr. Laura always starts there. So we always make sure that the meds are appropriate for the diagnoses when we do see that. But we haven't seen a lot of the atypicals used. I will say that. Anytime our red flag goes up, we always go to our partner with Dr. Laura. He's fantastic at working with us. He's very responsive, very involved. And then our pharmacy team does some outreach too to make sure that the meds are appropriate.
Surprising to me a little bit. I mean, are we going back to like the Haldols and that kind of stuff when we're not using atypicals? That just seems a little odd to me.
We've actually seen a lower volume of atypicals, and I don't think we actually have very many members at all that are on Haldol. And we do break it down usually by member, so we look at each member's regimen instead of looking at overall. We try to do that member-specific approach to make sure that what the member is on is appropriate for their diagnosis, and then what have they tried previously? So that's where we start when we do these consults. We start at birth. So we say, what's the birth history? Were they born early? Were they premature? What kind of trauma did they experience before they came into care? So we start at the main beginning and get as much information that we can, so that if we see a kid who's on a med that makes us question things, then we say, okay, what have they tried in the past? Is there a reason that we're doing this medication?
Yeah, thank you very much. And I agree with Dr. Brenzel that this is good work. I'm encouraged by the amount of teamwork that's going into this, and with an emphasis on non-medication interventions, so that we don't go first to a pill or something like that, but that we really try to address the child in the situation, whether with their family of birth or some other living situation, to try to do the intervention. So we certainly applaud the work that you all are doing over at Sky, and so appreciate your presenting to us.
Thank you for having us. And I would say we can't do it without DCBS and our partner, Dr. Lohr. So shout out to him and kudos to DCBS.
Right.
For walking alongside us.
I've known David a long time, and you've got an excellent leader over there with David Lohr. So thank you so much. We sure appreciate it. Let me go next to the next issue, and it's also about medications. I didn't get any specific issues with the Medicaid single formulary. I did want to tell you that I had some follow-up with some staff over at the pharmacy. April Prather is a PharmD over at DMS, and really was helpful to me in working with a prescriber about, and this was something that Val, you had brought up with an issue around dosages and getting Spravato approved and so forth. And I really appreciate the back and forth and the help that we got from the Medicaid staff in that regard. Chad Grant is on. There was a bill passed, a resolution, House Joint Resolution 28, about prescription digital therapeutics. And he's got someone who can give us a very brief overview of what PDTs are and how they are hopefully going to be used in our battle against substance use disorders and opioid use disorders. So Chad, if you want to introduce your person there.
Yeah, definitely. Thank you, Dr. Schuster. Joining us today is Dr. Scott Scheppers. He leads up all the medical team with Therapeutics. As many of you know, and I see a lot of familiar faces on the call, we've already had a pilot stood up through CORE. We're on our second pilot, and we're working towards trying to figure out, what can we do to get, Medicaid to reimburse us. House Joint Resolution 28 itself is asking Department of Medicaid Services to get some formal response from CMS. So we have a few months while that's happening. But I'm just going to hand over to Scott so he can give you a little bit of an introduction as to what PDTs are, and then hopefully maybe come back to behavioral health TAC and give a more detailed overview of some of the things we're doing specific to opioid use disorder and substance use disorder. So go ahead, Scott.
Thanks, Chad. Dr. Schuster, would it be possible for me to share a couple slides?
Yeah, Aaron, can you help do that, please?
Thank you very much.
You're very welcome.
Thank you, Aaron.
Let me find out how to do it. It just disappeared off my screen. Oh, here it is. Okay, so I'm just going to provide a high-level overview on the process to help us better understand what a prescription digital therapeutic is. So I think one way we can think of prescription digital therapeutics is just a new modality of treatment that are being introduced into the standard of care for patients. So we see at the bottom of the slide all of the different types of treatments that have been introduced to patients over the past 100 years or so. And I think of these as very similar in the sense that they're designed to treat serious disease with high unmet needs. But a prescription digital therapeutic is also very different in the sense that it's a treatment delivered via software rather than a pill or protein. But all of these different types of treatments are going through a similar process with the Food and Drug Administration, in which they have safety and efficacy validated and authorized by the FDA for their safe and effective use. They're also reimbursed through pharmacy and or medical benefits. But one of the other differences with a PDT is that it does provide real-time feedback to clinicians. So when you prescribe a blood pressure medication or an antipsychotic, we don't really understand in many cases how the patient is proceeding with their care, some of the outcomes until they come back for a follow-up session. But with a PDT, we have the opportunity to see that as the patient progresses through their care. So just a high level on how these therapeutics work through the FDA. They are authorized under a de novo or a 510K process as a class 2 medical device with special control. So these are neurological therapeutic devices with special control, which number 1 requires a prescription, and number 2 requires the submission of clinical data validating that this is a evidence-based form of behavioral therapy and that it's validated as delivered through the digital device. So these are reviewed by the FDA, and then once the FDA gives them their stamp of authorization, they enter the post-market surveillance system as well. So like a drug, safety is monitored, patient feedback, complaints, adverse events are all collected and reported out as required by the FDA. The final thing I'll just share is that this is a growing class. It's not a deep class at this moment, but we do see these different types of therapeutics entering the market from a variety of different companies. The first 3 that we see at the top of this slide are from the company I work for, Therapeutics, that we've used and have deployed in the state of Kentucky. Substance use and opioid use disorder, Reset and Reset-O, and Somryst is Pear's prescription digital therapeutic for chronic insomnia. We see some of the other therapeutics from other companies that have been through the FDA process that treat a variety of different conditions, including irritable bowel syndrome, amblyopia. We see some additional chronic pain indications among those as well. So again, high-level overview, happy to take any questions or schedule time for follow-up with the group.
Thank you very much, Scott. Any questions? Let me ask you, I think Chad told me that you all are in a pilot with the CORE program here in Kentucky. Is that right?
Yes, that's correct. Yep, I think we're in the second round. I can let Brad speak to the progress on that as well.
Yeah, I guess I was curious about at what point might you be able to give us some report about how successful the use of the therapeutics was in that trial. And Dr. Brenzel's on, he probably knows about it as well. I don't want to rush things, but I would be curious to get some feedback about it.
Yeah, absolutely. There's been one round. We'll actually, I think we're on the second grant through the core process. So there are some existing data, and we'll have some more data as the second batch of patients run through the next grant.
That's correct.
Just a comment. Just to comment briefly, obviously this is a prescription digital therapeutic. The issue is the core was able, through some of its proposals that it received, some of those grantees chose to use this as an intervention tool. The nice thing about that is that it did allow some data to be collected, not just national data, but Kentucky specific data. But the key issue is for long-term viability and sustainability. CORE is a transient grant program and the challenge is that if we build up provider familiarity, we build up demand and people spend the time to develop the ability to use this, we need a plan for ongoing sustainable funding of how this will continue, because CORE does not have the resources to sort of fund this for eligibility for all Medicaid recipients on the road. So I think that's where we are. CORE did have a limited number of projects that proposed, and we were able to fund those to get some good Kentucky specific data.
And Dr. Brenzel, I'll add, if there's anything that PAIR is willing to share, CORE is willing to share from the CORE specific data.
Okay, thank you very much. I guess my thought is that if you all are at the point where you CORE and PAIR are ready to present some data, I think we would all be interested in hearing that, the effectiveness. And Marcy asks, what about the cost? I don't know how you're handling cost at this point. And I assume that if you get Medicaid, approval for Medicaid coverage of the cost, you're looking at, and I don't know how long that process takes.
Yeah, Dr. Schuster, I can address that. The cost for the app is $17.98. We do partner in a number of different fashions, including value-based arrangements, bulk purchasing, pilots, grants through SOAR monies and ARPA funds. But for both Reset and Reset-O, the course of therapy does cost $17.98. With that presentation, we'd really look forward to is to be able to get into some of the randomized controlled trials that were impressive to the FDA, as well as the real world evidence that does show a dramatic offset to healthcare resource utilization, things such as ICU stays, in-house hospitalizations, and ER visits. So it more than saves the Commonwealth the initial investment. Shows tremendous ROI, but it's kind of hard and salesy to go into something like that without getting the baseline clinical behind it. We would welcome the opportunity. I guess we would rely on Chad to set that up as far as working with your schedules to relay that information.
Yeah, and certainly with the input of Dr. Brenzel, Dr. Marks, in terms of when CORE is ready to participate. I guess the other question is, I know the resolution directs our DMS to work with CMS toward approval for Kentucky Medicaid to pay for this. Do you have any idea about a timeline there?
Well, the only timeline we have, Dr. Schuster, right now is that because Sine dies, mid-April, we've got 90 days after that for the enactment date. They would probably be sending in their request, or at least what I've heard over from Cabinet for Health and Family Services, between July 15th and August 15th. And then the report itself is due back to the legislature, and that's both state and federal, by the end of the year. So there is a little bit of a timeline here that we're trying to work within. Obviously there's a lot of data we can share also from PAIR outside of just Kentucky. We have a lot going on already in Massachusetts and some other states where we do have agreements set up. So maybe if we did, another overview from a medical type of perspective, we could add in some background also where we are with other states. Maybe that would help.
Yeah, Marcy, you want to share what you just put into the chat? Marcy's with, is the Executive Director of Mental Health America of Kentucky.
Yeah, just letting folks know that MHA, NAMI, and Kennedy Forum have all worked together on, I believe there's pending legislation on this, but I know that they've all been very active in advocating for coverage of these kinds of things.
Absolutely.
All right, well, stay in touch, Chad. I know you will.
Oh, absolutely.
And we're happy to have you back. This is exciting. Anything that can help us better address our opioid use disorders and the more general category of substance use disorders is something that we're definitely interested in. So thank you very much for being here to tell us about it.
Oh, we appreciate the time. Thank you.
All right. A follow-up question. Val said, what was the name of the app for insomnia that you all have, the pair has?
It's called Somryst, SOMRYST.
Okay, did you get that, Val? SOMRYST. Thank you very much. Appreciate that.
Scott, if you would be kind enough to send me that, I'm happy to send it out to the board members.
Okay, great.
Thank
Yeah.
you.
Yes, thank you. Next item is our perennial item, update on claims payments for services to dual eligibles. And I guess Steve and Kathy Adams, I'll turn to you and ask where we are. Do we have progress? Do we have fewer problems?
I think there's progress on the Medicare side because there's a document that's been made available to the MCOs that really outlines those codes that it should be. It's really the Medicare bypass list. Very little progress. I don't know what the strategy is on the commercial side. It appears that's, and Kathy Adams can talk to that as well. You know, there's so many different commercial carriers. There's a large number. It's much more challenging about that list. We're still struggling to get that so it's clear and all those claims are paid. But there is a document that Medicaid provided to the MCOs that clearly, and the Medicaid issue is much easier to address because, you know, the Medicare is a fixed thing. The commercial side, we still struggle with that on a regular basis.
Okay, I think that Leslie yesterday just sent me that code list and we could circulate that out to folks. So I will do that after this meeting. Kathy, you have any update for us?
Yes, thanks. At the last behavioral health TAC meeting, we had obtained a copy of the Medicaid Medicare bypass list. Hopefully it's the same list you've got, or the one you've got's easier to understand. And we shared that back with Medicaid at the last meeting. I followed up and asked for some explanation on that list because it was hard to understand, and was advised that they are working on a more user-friendly, I guess, for the regular person to understand, and a version to post to their website. That was the last I had heard on the Medicaid Medicare bypass list.
Yeah, hold on just a second. And let me just say, I will send that out as soon as we get off this. I will send that out to all of you all who, you know, for whom I have emails. If you have not been getting emails directly from me about these meetings, please put your name and email in the chat so I can pick you up that way. Or better yet, send me an email at kyadvocacy@gmail.com so I can get you on the list. But I will send that list out so that everyone has it. Sorry, Kathy. Let's talk about the commercial list, which is much more an issue, I think, for the kids.
Absolutely. Right? The Children's Alliance took an approach where we reached out to each of the MCOs because we knew that some of them had commercial bypass lists, and we obtained copies of each MCO's commercial bypass list And 4 of the 6 MCOs have those. 2 MCOs that do not have the commercial bypass list, we ask specifically, how do you get paid? What is the process the provider must follow when someone has commercial to get paid? We have gotten one example or a couple examples from one of the MCOs where a member did not get paid after they did what the MCO said they needed to do to get paid, and they still have not gotten paid. And we're in the back and forth with the MCO and DMS on what needs to happen so that the provider can get paid. Because again, they did what the MCO said they needed to do. They got the EOB or a statement where the commercial insurance didn't pay, but because it didn't say that it wasn't covered under their plan, the MCO still wouldn't pay it. So, and again, you know, how much control does a provider have over what a commercial insurance puts on their EOB? So that is the concern where we are now. Again, it's 2 MCOs. The other 4 with the commercial bypass list, we're doing fine with those. So it's just the 2 that we're working on. And again, this has been going on for years, as Steve will attest to. And these providers just don't get paid when they're providing a service, a medically necessary service in good faith to a child that, had they not had commercial insurance, the MCO would have paid it. You know, so it's like these children are being penalized because they have commercial insurance. And like you've said several times, Sheila, is they should have better insurance coverage rather than less. So that's where we are.
And a lot of the services that aren't paid, commercial or even Medicare, never pays for. I mean, that's the real source of frustration. You know, so you end up, I know we've struggled a lot, Kathy, with targeted case management. You know, it's just not something that is paid for. And then, you know, and then our struggle has been when we need to get EOBs, they're not going to deny a benefit they don't cover, which kind of pisses me. So you don't get that document. And, you know, again, we've sung this song too long. And it's not a very good song anyway. But, you know, so, you know, it comes and goes. And I anticipate that in 6 to 9 months, there'll be more problems with folks who are dual eligible. It just kind of comes in waves. You know, it seems to be better for a while, then it becomes a problem. So,
who are you working with over at Medicaid, Kathy?
I forget the gentleman's name who has emailed me back. I think I've included both Sherry and Angie.
Mm-hmm.
Is
Angie Parker?
Yeah, let me.
Okay.
Let me look up. Oh, I don't. I've hooked off my PC. I can't pull up right now to see the gentleman's name.
Because originally we were working with Lee Geis on this, and I don't know. Leslie couldn't be on today because of a family issue, and both the commissioner and Veronica, Deputy Commissioner Cecil, had prior commitments. But let me get with them and see who it is that we need to be talking to over at DMS, because this is Steve Shannon and I. This goes back. This is like the SMI waiver, Steve. You know, this is 20 years of discussion, and it still just makes no sense to me that if you have 2 insurance coverages, you get poorer care. Well, you get the care, but the provider.
Right. The worst thing that can happen.
Yeah, it's the worst thing that can happen. It's almost worse to have dual coverage than it is to not have it.
And it does hurt the client, because what ultimately happens is providers quit seeing clients that have commercial insurance too.
Yeah.
Because they can't keep seeing patients and providing services and not get reimbursed. So they just have to stop. And that's what several of our members have done.
Well,
I
and
will
this-
get the gentleman's name that I'm working with at Medicaid and send that to you, Sheila. And then if there's
Okay.
anything else you need from
Yeah,
me, just
anybody
let me
else
know.
that you've been working with, and then I'll get with Commissioner Lee and Leslie and Veronica and see. I do remember now that a couple of meetings ago, Diane Shermer talked about providers stopping covering people because they had both Medicaid and Medicare. And do you remember that, Steve?
Yeah.
I think somebody stepped forward and said, you know, I think we can work this out on the side, but that is a very good point. And we can't blame the providers for dropping them. So
Kathy, are you by chance working with Justin Geringer? That's Lee Geis's assistant director.
No.
Okay, I just wanted
I
to
know
throw that out there.
Justin. It's
Okay.
not Justin, but I do think his name starts with a J.
John Hay.
I don't think so.
I'm out of J's then.
okay.
What was the last name you said?
Hay.
Okay.
Stuart Owen thinks it's Jeremy Armstrong DeRosa.
Oh,
Well, Kathy, let me know.
I think that's it. I think that's
think
it.
it's-
Yeah, I think
Jeremy.
that's the name I've heard before too.
he's
Okay.
under Angie's group, so that's probably right.
Okay. We just need to come up with an answer to this. So I will do two things. One is I will send you all out the bypass list that I just got yesterday from Leslie on the Medicaid, Medicare. And let's see how it lines up with what you've had in the past, Kathy. And then I will get with the higher ups over at Medicaid and see who is it that we need to work with. And we really need to maybe have a sit down on this because this has gone on and on and on. So thank you very much, Steve and Kathy, for your reports on that. On the no-show data gathering panel and how the data will be used, and we've worked on this for the last couple of meetings. And in fact, we made a recommendation to the MAC that Medicaid should send periodic reminders to all providers about the existence of this data gathering portal and encourage them to use it to report missed appointments and so forth. The interesting thing is, if you all watched the March MAC meeting, there was an item already on the agenda about this. And so there was a lot of discussion and a lot of people on the MAC chimed in that they were not aware of it and had not been encouraging people to use it. So I think our recommendation came at a very timely place. And I think the best that we can do is to continue to encourage providers to use that portal. It is a way to get the MCO's attention. And I think the reports we got at the last meeting from each of the MCOs indicated that they were using it in a very appropriate way to reach out, particularly with missed behavioral health appointments, to see what the barriers were, to see whether there was something in the social determinants of health or in their case management that they could assist with, which is really what we want. What we wanted to be sure was that people were not getting stigmatized in any way for no-shows, but that they were getting the assistance that they needed. So let's make a concerted effort for those of you who are providers and who have providers that you're working with, that we really make a concerted effort to get people to use that portal and report the no-show data. Any other questions or comments on that from anyone? Okay. We also have had several discussions at the last couple of meetings, and I think again, Kathy, this was an area that you had brought up some very specifics about the increasing number and requirements of the MCO audits. And I wonder if you're seeing any change, any improvement, any responsiveness to some of your concerns?
Yes, we have. At the last meeting, you asked each of the MCOs to let you know if there were any that had a less than a 30-day turnaround time, and they were going to follow up on that. I had examples from our members on where they had audit letters. One was a 5-day turnaround, and I think the other one may have been a 10-day turnaround with 2 different MCOs. And so I followed up and shared those examples with each of those MCOs. And the first was Humana, and got a response very promptly that they had reviewed their audits. And this was a new vendor that was going to be performing a particular type of audit for them. And so that they had talked with them and they were going to extend that time frame back to 30 days. So then all their audit letters should be 30 days going forward. So that was Humana. And then also worked with WellCare, and they only have one audit letter that did not have at least a 30-day turnaround time frame. And that was the example that I had from a member, and it was specific to a HEDIS audit. And they have agreed to extend the turnaround time on those to 14 days with the option for a 30-day extension. So what I've been told is that all of WellCare's audits now are at least 30 days, except the HEDIS audit. You get 14 automatically, and then you also have an option to request 30 days. And as far as I know, the other 4 MCOs, I've not received examples that they have any audit letter less than 30 days. And I'm not getting the complaints I was getting either. So I don't know if the audit letters have slowed down, but or it could just be that our members are in crisis and they don't have time to respond. But I am not hearing any complaints, which is great. And a special thank you to the folks at Humana and WellCare for working with us and being collaborative.
And I did hear back, I think everybody reported at the meeting, with the exception of maybe 1 or 2 MCOs, and I got follow-up emails from them, and all of them said that their audits were 30 days. So I think maybe, again, for those of you who are providers who represent classes of providers or groups of providers, I think the expectation should be that all audits should have a 30-day turnaround time. And if not, then, get back with the MCO directly. Our understanding is possibly with the exception of WellCare and the HEDIS. But remember, and Angie Parker has said this over and over again, as has Veronica Cecil and Leslie Hoffman, it is the prerogative of the provider to ask for an extension. So instead of killing yourself to get these things in when it's an inappropriately short time, ask for an extension to 30 days, which should be the norm. And you can let me know, or if you're obviously in the Children's Alliance, let Kathy know, or if you're one of the CMHCs, let Steve know, so we can stay on top of that. But I'm glad to see that we've had some improvement in that. Have you heard anything otherwise, Steve, that's different than that?
No, I have not.
Good. Maybe we can take that one off the agenda going forward. Status update on the SUD waiver. I know Leslie's not on, and I don't know if anybody else from Medicaid is prepared to give that update.
Hi, this is Dr. Terrio.
Hi, Dr. Terrio.
How are you doing?
Fine, thank you.
There's really no update. It's still in CMS's hands, and monthly it is brought up on the CMS meetings, and they're working through the budget neutrality. So it's basically the same update as last month and the month before that.
Yeah, thank you.
And that's the update we got on the persons returning to society from incarceration TAC this morning.
Okay, all right. So I'm marking that, I think that waiver was submitted maybe in July of 2019.
November.
November? Okay, I
Yep.
was thinking that we had worked on it all that summer, and maybe we were working on the comment part is what I'm remembering. So we're going on, we're a year and a half at this point.
No,
3 years.
3
Almost,
years.
yeah.
3 years.
3 years in November.
Oh, 3 years in November. Okay. So we keep hoping that there will be positive movement on that, and we will keep it on. For those of you who are not familiar, it is a new direction for CMS to go because typically Medicaid services are not possible if someone is incarcerated. And this is really an innovative waiver that would allow incarcerated persons who are Medicaid eligible to receive SUD treatment while they are incarcerated. And, you know, probably even more important or equally important, it really sets up a continuity of care that the moment that they come out of incarceration, that Medicaid service array continues to be available to them. They're hooked up with an MCO and so forth, so that people don't drop through the cracks. So we're anxious for that to get approved. And Kentucky would be the very first state to have such a waiver. I understand that a number of other states have looked at our application and are trying to mimic it and lean on CMS to also get approved. So we'll see. Would be nice to be out there first on something like this. I sent out late yesterday kind of quick and dirty summary of actions taken by the Kentucky General Assembly related to behavioral health. And actually it was kind of an upper as I looked at, and these were just bills that were passed. There were many other bills that you know, had to do with behavioral health that came close or had some discussion and did not pass. But you have that list in front of you, ranging from the budget issue to a really innovative approach in House Bill 44 that came from students to have an excused absence for a mental health issue. Unfortunately, it was watered down in the Senate to make it leave it up to each school district to determine if they wanted to do that or not. But it's still, you know, is a movement in the right direction. And the fact that it came from a rural-based student and an urban-based student who both came to their legislators with it and were able to testify in Frankfurt on it, is very positive. We continue to see more licensure compacts passed by the legislature. These are the ability of a particular group of providers, in this case, the licensed professional counselors, to enter into an interstate compact that would ease reciprocity with other states. This was one of the recommendations also from the SMI task force. The year before this session, the psychologists passed a compact. So we're, you know, we're moving forward with the idea of easing reciprocity. House Bill 79 identified PTSD and provides treatments for telecommunicators. Those are the dispatchers. And quite frankly, I for one had not thought about dispatchers as first responders, but if you think about trauma, they're the ones that are getting those calls immediately when a situation is going on. Very often stay engaged by phone with the person who is making the report, and they were able to identify that some of these folks are really suffering then with PTSD following that trauma and hearing about that trauma and then knowing the outcome one way or the other. So this was a very positive bill. Representative Duplessis made some changes in telehealth and answered some questions that a number of providers have had. He talked with me about this at the beginning of the session. This again came from a constituent. I think it was a youngster with an eating disorder, and we know how difficult it is to get treatment. And the youngster was out of state. I think a college student was on spring break and calling back to her therapist in Kentucky, really in crisis and needing services, and was told by that provider that they didn't think that they were able to do that, to provide those services if the client was out of state. So this really requires the licensure boards to make telehealth available, whether the provider is in state or not, and whether the client is in state or not, as long as they're duly licensed, appropriately licensed, and it's a covered service. So hold on one second, please. Thank you. Another bill was a psychology bill that required 3 hours of CE on social and cultural factors, really brought about by the telehealth boom. So you have essentially urban psychologists that are now able to provide services to rural Kentuckians who have some cultural, language, and social mores that are perhaps different, not as familiar to them. And we want to be sure that psychologists are up to date on social and cultural issues. Also allows pre-doctoral interns to qualify for licensure as licensed psychological associates so that they can be reimbursed by Medicaid during their internship. We're hoping that this will grow the number of internships for graduate levels, doctoral level psychology interns in Kentucky. We know that if people come for internship, very often they stay where they have their internship. So it's a way to grow the psychology workforce as well. House Bill 362 was Representative Moser, and many of you remember Casey's Law. It's Charlotte Whitaker's son, Casey, who died of an opioid overdose in early 2000, and she has worked tirelessly to make sure that there's a way to get treatment for someone who really doesn't want to or doesn't acknowledge that they need treatment. So it's been on the books since 2004. And there were some questions raised from a legal standpoint about how the diagnosis was being made and whether it was subject to subpoena or not. So those few technical changes were made to update Casey's Law. And it is in effect right now. It was passed with an emergency clause, which makes it immediately applicable. House Bill 777, and I see that Claire Arendt from Kentucky Hospital Association is on. This was a bill that had, I don't know, Claire, 2 or 3 numbers previous to this, Representatives Fleming and Moser. And this was an attempt to make sure that all patients, whether for physical or behavioral health reasons, would be transported from one facility to another without inordinate delays. And so this ended up being a battle between the city governments and the county governments. It was a battle with the ambulance providers. It was something that the Hospital Association, the Mental Health Coalition, the nursing homes and hospice all wanted. And we've talked before at these behavioral health TAC meetings about ambulances coming and saying we don't have to transport those crazy people and refusing to take people. So hopefully with an oversight board that actually someone from KMHC will be sitting on, we'll be able to nip those problems in the bud and make sure that people get the transportation that they need. HJR 28, we just talked about a little bit with the prescription digital therapeutics. And again, this is simply asking our DMS to request guidance from CMS for Medicaid coverage. Senate Bill 90 is something that Senator Whitney Westerfield made his top priority, worked with President Stivers and Senator Storm. This establishes actually a diversion program for behavioral health conditions, both SUD and mental health. It would be in 10 counties beginning in October of this year and going for 4 years. And it would allow eligible individuals a treatment alternative instead of incarceration, could result in the dismissal of the criminal charges upon successful completion of the program. A little side piece is, and I thought it was interesting, also establishes telehealth services in jails, because we know that there are suicides in jails. We know that there are many people with mental illness in our jails. So an excellent piece of legislation, was a long time in the making, and we applaud Senator Westerfield for hanging in there, because it had many ups and downs during the session. Senate Bill 102 was Senator Max Wise, who's chair of the Senate Education Committee, and it makes a technical correction to the School Safety and Resiliency Act to include school psychologists and school social workers in the required data collection for school mental health providers. Previously, it had been school counselors only, but it put school psychologists and school social workers. As a side note, they had requested increased funding for school mental health providers, but I don't believe that that ever made it into the final version of the budget, which was unfortunate, because we certainly are hearing, and Steve sent out yesterday a compelling article from the New York Times about Glasgow, Kentucky, and the pediatricians being overwhelmed with the number of adolescents needing mental health services, and we certainly are hearing that. Senate Bill 140 is a good bill. Val, I think you and other consumers would certainly agree. This again is Senator Wise and then Senator Danny Carroll from Paducah, to prohibit insurers from instituting step therapy protocols. This is the old fail first. You know, we're going to try you on the old psychotropic medications like Haldol and make you fail on that before we're going to give you the more expensive medications, and so this would prohibit that. Senate Bill 178 with Senator Julie Rocky Adams became what we call a Christmas tree bill. It started out as a very, very simple bill that addressed some need for more licensed alcohol and drug counselors to be able to provide supervision immediately. There's been such an influx of applicants to get that credential, and the required supervision was not being able to be met. So they've lifted some requirements for those supervisors, but then a number of other, I think, good pieces of legislation got attached to it. One was from Representative Joni Jenkins to allow licensed narcotic treatment programs to use buprenorphine products. Another establishes an opportunity for a new mother giving birth to a baby with neonatal abstinence syndrome to participate in drug treatment to avoid termination of parental rights. So right there at the hospital, once a baby is born and is diagnosed as having NAS, the mom doesn't automatically lose parental rights at that point if they're willing to agree to an evaluation and participation in drug treatment. And then something that's not just behavioral health, but something that many of us have been working for years, requires Medicaid coverage of healthcare for mothers for 12 months postpartum, which I think is going to be a real godsend. There were several bills I can think of that were not successful that address postpartum depression, which is a growing concern and one that is really shows the health inequities. The incidence of, unfortunately, successful suicides by Black and brown moms is, I think, twice as much as for white moms. And so the whole, I think, maternal health is a theme that we saw through this legislation or legislative session. So the Christmas tree bill had some good things on it. As you all know, we talked quite a bit about the task force on severe mental illness. And so I listed these separately. Senate Joint Resolution 72, Senator Alvarado requires the cabinet to apply for Medicaid waiver for Kentuckians with severe mental illness to provide supported housing, including staffed residences, personal care homes, group homes, and other residential options, as well as medical respite, and also including supported employment services. And it was signed with an emergency clause, so that goes into effect immediately. This was the #1 recommendation of that task force, and something that some of us have been working on for, oh, I don't know, 20 years or so. Something that is much needed in terms of particularly the supported housing piece. House Joint Resolution 5, Representative Fleming, Wilner, Bentley, Prunty, all were on the task force, and then Representative Palumbo encourages the licensure boards to either get into reciprocity agreements, to join compacts, or to reduce reciprocity requirements to increase the mental health workforce in Kentucky. House Bill 127 also came out of that task force, and it made recommendations put up forward by Judge Stephanie Burke from Louisville District Court, who's done one of the few Tim's Law cases, to make it more broadly applicable and to rectify some timing issues. A huge success, something that NAMI has worked on since 2008. It only took us 15 years. The passage of House Bill 269 to exclude individuals with a documented diagnosis of SMI whose symptoms were present at the time of the serious felony offenses for being subject to the death penalty. So that's cause for great celebration as far as I'm concerned. We had done that for people with intellectual developmental disabilities, and also for youth 16 and 17 years of age. So not to have done it for people with impaired ability to make reasoned decisions has really been criminal. House Bill 645 started out as 645, but it passed as House Bill 604. And this was the baby of Representative Danny Bentley, who was on the task force as well. His Comp Care Center Pathways has mobile crisis units that go to homeless shelters, that go to rural areas where it's difficult for people without transportation to get to both physical and behavioral health. They're equipped, some of them, with a behavioral health person and at one end of the trailer, and physical health needs at the other end of the trailer. So it was attached to House Bill 604. That was passed after the veto session on the last day of the session, and the governor did veto some line items, but not the ones that had to do with the mobile crisis unit funding. And then the final piece, House Bill 730 from Representatives Bray and Heverin, really initiated some discussion that needed to be had around the involuntary transportation of involuntarily committed individuals to a state psychiatric facility. So it reduces the time for detaining the individual, requires the cabinet to monitor and maybe review the assignment of counties to each of the state psychiatric facilities. So those are the ones that came to mind. If anybody has others that I missed, I'm happy to hear from you, or if you have any questions about any of these, happy to try to answer those. All right, hearing none, I'll see that as approval of the list. Thank you. I also sent out a updated guidance document, prior authorization guidance, effective July 1st, 2022. PAs will be required for SUD residential and inpatient treatment services of the various ASAM levels. Can you put that up there, Erin? Do you have that?
I don't, but give me just a second and I will.
Thank you. I think it's important to realize that this is only about SUD, and it's only about residential and inpatient. I got a question from someone who said, oh, it's behavioral health. And I said, or mental health. And I said, no, it's SUD. So I just want to make sure that people, what I don't know, and I don't know, Steve, if somebody from DMS, what are the different provider types that are listed there? Are you familiar with them? 02, 03, 06? Okay. Is there anybody on?
Hi, this is Kat.
Yeah, Kat.
So 03 is your BHSO. Your 02 is going to be your psych hospital, and 06 is going to be your CDTC, your chemical dependency treatment center.
Ah, great. Thank you very much.
Can you see it now?
Yes. Yeah.
My apologies, my computer's running a little slow.
No, thank you. And I should have let you know that we wanted to see that. So the second point that's bolded is just the reminder that all other behavioral health and SUD services continue to be waived, meaning the prior auth for all of those continue to be waived. And Claire, thank you. Claire has just put a provider type reference into the chat for us. Thank you very much. So we appreciate whoever is on from DMS getting these on a regular basis and being able to circulate them. So you all have that, and it goes into then specific services and so forth that would be required. But again, this is SUD only, and it's residential and inpatient treatment services only. Any questions from anyone about that? I probably won't be able to answer them, but you can ask the question and then we'll see if anybody can answer them. All right. Thank you very much, Erin. Appreciate it. Any new recommendations to the MAC? I don't have any. I don't believe we got any feedback from DMS on our last one, which was about making sure that providers know about the no-show portal.
Dr. Schuster, I haven't received your MAC recommendation back yet, with Leslie being out of the office with a family emergency.
Okay.
So as soon as I have that, I will get that out to you.
All right, thank you, and I'll send it out. I do have an announcement to make since we're talking about the MAC, and that is that I received a call from the Governor's Office of Boards and Commissions, and I have been appointed to serve on the MAC. It is the first time that we've ever had a specific behavioral health provider on the MAC, so I'm thrilled to be in that position. And my first meeting will be the May 26th meeting. So just remember, you have a friend on the MAC. Thank you for your support. Any recommended agenda items for July 2022? I'm hoping that we'll have a report to share with you about the targeted case management data. And I do appreciate the work of the EMS data team and working with us, because we have lots of very detailed questions, and then we get new information and we change our mind about what it was that we were asking about and so forth. So I really do appreciate everyone's work on that. If not, then just a reminder that the next MAC meeting is May 26th, 10 o'clock, and I will send the Zoom out. I really recommend for you all to join those MAC meetings. The commissioner and the staff give regular updates, and you get a ton of information right there, very concentrated. And you also get a sense from hearing from the different TAC groups, what different provider groups and advocacy groups like the consumer TAC and the reentry TAC are working on, the Children's Health TAC, for instance. So if you have that time available from 10 to 12:30, they're open via Zoom, and it's posted on the website, but I also always send it out to people ahead of time. I really encourage you to do that. And then our next meeting will be July 14th at 1 o'clock. And we're back on a 1 to 3. We'll be on 1 to 3 time frame for the rest of the year. We only do the 2 to 4 during the legislative session. I think there was, unfortunately, a little confusion because the website still had us in May 2 to 4, but Aaron was Johnny on the spot and got to that and corrected it. So we appreciate that. Is there any other business to, oh, yes.
Sure, I have something regarding your next meeting, if you have just a moment.
Yes.
I've been trying to put it on all the tax radars. At this moment, I'm not currently in the conference room. People who outrank me needed it, so I stepped into a private office. So we are putting on the radar with the tax who may want to come back in person. I know so far we've had a lot of hybrid options have kind of been the preferred. As far as I know right now, we are still having the option of the Zoom, but I did want to throw that out there. If there are anyone who does want to come in person, we'll always provide the Zoom link for people, throughout the state who want to join. So I'm just kind of putting that on everybody's radar and letting them kind of discuss, amongst themselves, which they prefer. I don't know how many of you may travel from out of town. I was able, and Steve could probably, he did get to actually see the conference room today. So I'm going to pretend they're behind me. We've got about 12 seats or ish. If we all squeeze in, everybody could be seen on camera, but it may just have to be an option with, especially some of the larger TACs where it's kind of split up a little bit. I know so far a lot of the feedback I've gotten is that people don't have to drive to Frankfurt. They'd prefer not to, but may pop in here and there if they're in town, or maybe just to have a in-person interaction. And so I'm just kind of putting that on all the tax radars and kind of getting some feedback of where you guys stand.
Thank you, Aaron. Let me hear first from the voting members of the TAC, and then we'll open it up. I wonder, Steve, Valerie, TJ, Eddie, Mike, what's your feeling about in-person versus hybrid versus staying strictly with Zoom?
The reentry TAC, Persons Return Society TAC, met this morning, and Aaron raised this issue then. I listened in on the primary care TAC last week to discuss there, and we talked about it this morning, and we have 12 members. So I'm not convinced 12 fits in the conference room comfortably. I mean, I think it'd be okay, but not great. Also, we have folks who, coming from obviously like this TAC, far away places, essentially 2.5, 3 hours away. People on Central Time, we meet at 9, so it's really hard for them. We made a decision for the hybrid model. So the Zoom is available. Obviously, I think the rule's always been, Aaron, that if you're a member of the TAC, you need to be on camera. So we know you're actually there, as opposed to just, someone turn your computer on to Zoom. But I think we're going to stick with that hybrid approach. I think I'll attempt to attend in person regularly as the chair of that TAC, just to be there. I know there's another TAC member whose office is in Frankfurt. There's a good chance that person goes to the CHR building for the meeting. But the consensus we had this morning, and I heard last week at the primary care TAC, was to maintain the hybrid model as long as possible. And so you have the Zoom option available, but people who want to attend in person may attend in person as well. So, but the conference room, I don't think it's the new conference room. It's been the same space. And, there are some chairs on the outside. It'd be really hard, when we used to meet at the LRC building, Sheila, room 125, we'd have, I don't know how many people there. Today we had 60 plus,
Right.
so I think The in-person is challenging for sure, but the hybrid makes the most sense. And it does cuts down on travel, obviously, for people. So
Yeah.
it becomes a 2-hour meeting. There's a gentleman on the TAC that we had this morning at 9 who lives in Owensboro. You know, to be there at 9, he's leaving his house at 5:30 a.m. So he'd prefer not to do that. And there's right now no requirement to do it in person. It's still available. So my recommendation is the hybrid model makes the most sense. And if folks want to be in person, you know, they get to hang out with Aaron for a bit in the CHR building. I'm sure that's a thrill for Aaron. But, you know.
I'm sitting in that big old room alone this morning.
Yes, that's right. You can hear the
I'm not
echo.
opposed to company.
Yeah. So.
The only thing I need to know, and I went over the TAC this morning, is if anybody wants to come in and be in person and hang out with me in the meeting room, just let me know a couple days ahead of time so I can let our security desk know. And then that way also too, they can let me know when you're here so I can come down and greet you and walk you up through our Medicaid maze instead of just hoping you find us.
Yeah. And that gives Erin enough time to get her Starbucks order into that person as well.
I knew I liked you, Steve.
So Aaron, you have a regular conference room. What floor is that?
So we're on the 6th floor. We've been trying to work with the cafeteria conference room.
Yeah.
The issue down there is there's no phone line for virtual things. And like, I can't remember if it was this morning or if it was the children's TAC the other day. We do have this equipment that does help record. And when I first heard about it, I thought it was a little recording system. It's probably bigger than my TV. And if I broke it, I can't afford to replace it. So I'm hoping to not have to move that too much. Public health with the really large rooms have really just kind of cut down on only letting their staff use it. So if we get to a point where more people are wanting to come hang out in person, I can start trying to figure out what we need to do as far as getting us a bigger space and still being able to comply with all the open records and recording. I'm sure you guys all know if you missed the meeting, I try within a couple of days to have this uploaded to our YouTube site. So that way, if you do miss something, you can go back and physically watch the whole meeting versus having to just go through and read all the minutes. Or if you're interested in other TACs, they're always posted as well.
Yeah, thank you.
So will it not be an option to meet at the annex any longer? I know we were kind of rebellious and we kept meeting there, even though the commissioner at the time was very reluctant to letting us do that.
I would have to reach out to LRC about if they're opening their spaces right now. So I would just, if that's what you guys would like.
I mean, like they say, we just have such a large group, number one, you know, and we just like that space. We always have liked that space, so.
Yeah, I think that's, and I think, Aaron, I don't think you need to reach out right now until we get more of a sense of a groundswell of people that, you know, want to meet in person. I think our numbers have been very good during the Zoom time. Actually, not a whole lot different. We probably had 40 to 45 people in person when we met at LRC, but probably somewhat more with Zoom. I wonder, Mike or Eddie or TJ, any thoughts about the meetings and how you would like to see that happen?
I'm with hybrid.
Okay.
Absolutely. I think this day and age, you know, some things are going to be residual from COVID, even when it's winding down. And I, you know, for efficiency purposes, I think it's absolutely the right way to go.
Okay.
I agree with that.
All right. So I guess what we ought to do, Aaron, is when I send out notices and so forth, is to let people know that if they do want to come in person, it would be at the CHR building, and that they need to let you know a couple days in advance.
At least a day in advance so I can let the security desk know so they don't fuss at me.
Yeah. I will tell you that as of right now, I'm still, my daughter, the nurse, keeps reminding me that I'm high risk, which means that I'm old. And I've done very little in-person stuff even during the session. So I'm going to stay Zoom. I'm happy if Steve or anybody else wants to be there in person, but let's just leave it with the hybrid then at this point. But thank you for bringing that up.
You're very welcome.
And we do have one other thing. Aaron, can you put that basic health program provider notice up for a minute? The BHP.
Oh, hold on one second.
Sure. This again was something that I sent out last night because we had just gotten it. It's the basic health program provider notice. Which I had heard just little bits and pieces about, but not much. I'm guessing that, I think this came out of HJR 57 from a year ago, the development of a basic health plan. It also is, I think, being set up, and I welcome input from anybody from Medicaid who is on, Dr. Terrio or others. We know that with the decoupling or the unwinding, rather, once the federal emergency period goes away, that there will be a lot of people who are going to lose their Medicaid coverage. They had Medicaid and the feds required that if you were going to keep your Medicaid during the emergency period, that no one could lose their Medicaid. So we know that there are people for whom there has been changes in income and so forth. And there we go. Thank you so much.
Sorry about that.
So, yeah, this is a bridge with coverage between a qualified health plan and state-based exchange. Hold on one second.
You're muted, Sheila.
Sorry, I have to talk to my granddaughters for a minute.
Okay.
So I understand that this is being developed. It's not been completely fleshed out. And I understand from Veronica Cecil via text today that they will keep us in the loop as we go forward. I think one of the questions, and Steve, you asked a question and got a response about benefits.
Yeah, I think it's going to be similar to the standard plan behavioral health benefit. I'll find that email. I reached out to Commissioner Lee last week about this, and that was her message, as well as we'll be in touch.
Okay. I think the other question that's come up is if providers are going to be contacted, I guess, by the MCOs to be in the network, then are those payment rates going to be negotiated by the MCOs, which is what I understand. Is there anybody from Medicaid that can share a few words about this, or is this what we know at this point?
Hi, this is Dr. Terrio again. That's basically what we know. A lot of people are working pretty hard on trying to get this done so it's up and available because we don't want anybody to lose coverage when we start doing those certifications. And so we need to, have something for people to go to. But I don't really have any more than what you've already said.
Yeah. Okay. And the message from Commissioner Lee, when I asked her last week, is that the basic health plan or basic health program has to provide the 10 essential health benefits, including mental health parity. So I think that's the guide from the exchange, and there'll be stakeholder engagement coming soon.
Okay. Well, we're delighted to hear that it will have the MH and SUD coverage and that it will be at parity. And I think, Dr. Terrio, if you don't mind taking back the message, I mean, certainly those of us on the BH TAC are happy to be of whatever assistance we can be, either, in communicating with the work group or in getting the word out, or having some of our consumers go through. We've done this before, and Kentucky Voices for Health as well has gotten consumers to look at something and give you some feedback about the readability and understandability of it. So in any way that we can be of help, we're happy to be of help.
Thank you. Thank you very much.
Okay, thank you. So that is all that I have. Is there any other business to come before the BH TAC? I'm still letting you out a little early, folks. Just not quite as early as I thought. All right, well, we will adjourn the meeting at roughly 2:50. And Erin, thank you again for all of your assistance. Thanks again to the Sky program at Aetna for an excellent presentation, and to Pear Therapeutics and for good interaction. Appreciate it, and we will see you all in 2 months.
Care.
Bye.
Good summer. All right, thank you.
We'll see you all on Bastille Day.
That's right. And let's not storm it.
Correct. See ya.
All right, bye-bye. Thank you.